Good evening. On behalf of the Emirates Diabetes and Endocrinology Society, I'd like to welcome you all to tonight's webinar. It's the first of 3 webinars on dyslipidemia, and we're very grateful for the educational grant from our sponsor Amgen that has allowed this to happen. We have 3 excellent speakers, but before I introduce them, a couple of housekeeping rules. If you're unable to join, then there is a live stream on the Society's YouTube channel. The webinar will also be available on demand on the Society's website, and you can see that in the middle. You can type any questions that you have in the Q&A box, and after the three first talks, there will be a time for some questions. It's accredited for 2 CMEs, which after you give your feedback will be available. And if you have any technical difficulties, the number on the screen, please take a screenshot or photo of it, are able to help you on that. Without further ado, we'll move on to our first speaker, Professor Borg Nordahl, who's a professor from the University of Copenhagen in Denmark. He's the chief physician in the Department of Clinical Biochemistry at Copenhagen University Hospital. He has over 35 years of expertise in the pathogenesis, diagnosis, and treatment of hyperlipidemia, atherosclerosis, diabetes, and cardiovascular disease, and has written extensively on these conditions. Today, he'll be speaking to us about risk assessment and stratification for primary prevention. Professor Borg, the floor is yours. Thank you.
Can I start share my screen?
Yes, please.
So I hope you can hear me. So first of all, thank you very much for the invitation to give this presentation at the AIDS Connect webinar. My name is Borg Nordahl, and I'm from University of Copenhagen. My conflict of interest are shown below. A very key document for my presentation here is, being a European person, is the 2019 ESC Guidelines on the management of dyslipidemia, lipid modification to reduce cardiovascular risk. The 3 most important lipoproteins causing atherosclerotic cardiovascular disease is LDL, that's the main focus on the guidelines, but there's also mentioning of lipoprotein(a), lipoprotein(a) being an LDL-like particle with this extra apolipoprotein on top of it, ApoA, consisting of these crinkle-like structures. And then there's the very much larger lipoproteins, the remnants, the VLDL, or you could call them triglyceride-rich lipoproteins. They all have ApoB containing lipoproteins depicted here. And so you can measure ApoB to have all of them together, or you can measure non-HDL cholesterol, so all the cholesterol not being in HDL. Here's the same 3 fractions, but now I try to show exactly for an average population, these are American data, how much cholesterol are found in different fractions. So in LDL for the average person, 115 milligram per deciliter or 3 millimoles per liter. For Lp(a), on average, it's much less cholesterol. It's only 3 milligram per deciliter or 0.1 millimoles per liter. So Lp(a) may have a different role than just delivering cholesterol. And then there's the remnants. Here you have 25 milligram per deciliter or 0.6 millimoles per liter on average, but some patients have a lot more, and there can also be a lot of triglycerides in these fractions. But notice it's likely the cholesterol content that causes atherosclerosis. So here's my simplified view of the different lipoproteins, how they lead to disease. LDL leads to atherosclerosis, maybe more stable than unstable plaque. Then there's the remnants or triglyceride-rich lipoproteins, also leading to atherosclerosis, but maybe particularly inflamed unstable plaque because of the triglyceride degradation. And then there's lipoprotein little a. Many people think, and I also used to think, that maybe it would cause atherosclerosis like LDL. However, as I just showed you, it does contain quite small amounts of cholesterol. So it's also possible that if you have high LP little a, it indirectly can promote thrombosis by fibrinolysis inhibition because ApoA has homology with plasminogen. We used to hear a lot about that HDL could protect against atherosclerosis, but this hypothesis is gone now. So please forget about this hypothesis. The three lipoproteins relevant for atherosclerosis, atherosclerotic cardiovascular disease, LDL, remnants, and LP little a, the ApoB containing lipoproteins. Here's a simplified cartoon of how we believe the pathogenesis happen. So if you have a VLDL from the liver or chylomicrons from the intestine, they're too large in the beginning to come into the arterial wall. They simply cannot enter into these through these endothelial layer into the intima. However, they are very fast degraded into remnants and maybe even further into LDL. And then they can enter into the arterial intima. LDL needs some sort of modification before it can be taken up by macrophages to produce foam cells. However, the triglyceride-rich remnants can directly be taken up to produce foam cells. As this keeps developing with more and more LDL and remnants in plasma, maybe because of endothelial dysfunction can also help more entrants come into the arterial wall, then these fractions will lead to more and more foam cells, more and more atherosclerosis, unstable plaques with inflammation, particularly from the triglyceride-rich lipoproteins. LP little a can also come into the arterial wall, but we don't really know about it causes atherosclerosis. As it develops yet further, then you can have a ruptured plaque, and then you will have a thrombus formation, where maybe here LP little a particular can, as I said before, be part of making the thrombus grow and then lead to myocardial infarction or stroke. This is a key feature of the 2019 European ESC Guidelines. You have to take into account two things, namely, how low do you want to bring your LDL down, and what is the risk from low to moderate, high, very high. So the higher the risk, the further you want to bring down LDL cholesterol. As you can see, for the very high, certainly all the ones with atherosclerotic cardiovascular disease, myocardial infarction, stroke, that's the two most important, but also with a so-called score risk more than 10%. I'll come back to that. But there's also other here, FH with ASCVD, severe chronic kidney disease, diabetes mellitus, some of them. And then less severe disease are high risk, corresponding to a score of more than 5 to less than 10% of fatal cardiovascular disease. Then there's the moderate risk between 1 and 5%, and then there's the less than 1% score risk. The recommendation for cardiovascular disease risk estimations in this guideline is in 3 steps, 3 stages. First, a clinical evaluation, and here the focus is on if you have documented cardiovascular disease, diabetes mellitus, moderate to severe renal disease, very high levels of individual risk factors, familial hypochondria, or a high risk score, class 1C. Then the next stage would be score 10-year risk estimates, where the total risk estimation using the score system. I'll come back to that. And then finally, there can be assessment of risk modifiers, particularly with focus on increased ApoB, lipoprotein little a, C-reactive protein, a family history of premature atherosclerotic cardiovascular disease, or the presence of atherosclerotic plaques on imaging. Here's the score system, European. You can look it up on the internet, just put in score and ESC, and it'll come up automatically as a calculator. What the focus here is on to both look at women versus men, non-smoker versus smoker, different ages, what is the total cholesterol, and what is the systolic blood pressure. And then, so if you have a non-smoking male, age 60, with a systolic blood pressure of 160 and a total cholesterol levels of 6, you'll get to roughly this 10% risk of dying of cardiovascular disease within the next 10 years. So all the ones with the reds are really high risk. Those are certainly the ones that should have a statin. In the guidelines, very high risk, calculated score risk more than 10% for 10-year risk of fatal. The high risk between 5 and 10%, the moderate risk between 1 and 5%, and the low risk less than 1%. So SCORE, this risk tool, can be used to estimate risk in patients who do not have clinical ASCVD or any other clinical features that define a risk category. For very young people, there's also provided this chart that doesn't take the age into account. But if you have a young person and you want to convince the young person to do something about preventing cardiovascular disease, then you can do this on a relative scale. So if you compare a young person, for example, you could say it's a person that has a total cholesterol of 6, has a systolic blood pressure of 160, is a smoker. Then that person has 6 times as high risk of dying of cardiovascular disease as this person down here, the non-smoking, 120 systolic blood pressure and 4 in total cholesterol. Very good for young people. Then who should then be treated? And then there's this, you could say, complicated version of looking at it, but it's also a way to target both LDL cholesterol levels and risk. So up here you have lower LDL cholesterol. So the very highest, more than 4.9 millimoles per liter, that's more or less corresponding to familial hypochondria, and then lower and lower levels. And if we focus down here now on the secondary prevention, so that's a very high risk, then essentially the red means that you both do lifestyle intervention and you do drug treatment. So if you have atherosclerotic cardiovascular disease, you will bring LDL cholesterol down to as soon as it's more than 1.4 millimole per liter or more than 55 milligram per deciliter, you will bring it down by drug treatment. Focusing now on the primary prevention, then the ones with the highest risk, you will try, if LDL is above 70 milligram per deciliter, to bring it down. If the risk is between 5 and 10, you will focus more on if it's more than 100 and so forth. But notice, even the ones with the very lowest risk, if at the same time they have LDL above 4.9 millimole per liter or more than 190 milligram per deciliter, indicative of potential familial hypochondria, drug treatment should be initiated together with lifestyle changes. Here's a couple of papers that I did together with Martin Mortensen, also from Denmark, where we tried to compare the five major guidelines in the world for prevention of atherosclerotic cardiovascular disease. The ESC Guidelines, as I showed you before, the Canadian guidelines, one American guidelines, the main American guidelines, ACC/AHA, and the UK NICE guidelines. And what it shows here is the percentage of individuals eligible for statin therapy as a function of age groups from 40 to age 75. And as you can see, that the majority of guidelines, once you get up to above age 60, 65, then more than half, and at the very top group, close to 100% should be offered statins according to these guidelines. The outlier was the ESCAS guidelines, but then this was the 2016 guidelines, and they changed it for the 2019 guidelines. So now you can see the European guidelines, as for all the American, the Canadian, the American, and the UK guidelines suggest to use statins in people at a certain age substantially. In a third publication, Martin Mortensen could also show here that if you look at the 5 different guidelines, how many do you need to treat for 10 years to prevent one atherosclerotic cardiovascular disease event? And if you use high-intensity statins, it's approximately 20 persons you need to treat to prevent one event, irrespective of which guideline you follow. Here, what I've tried to show, this is my personal point of view, following lipidology for many years. So what is the clinical focus on lipoprotein for cardiovascular disease prevention? Here on the y-axis, 100% versus no interest clinically. And on a time scale from 1970 to year 2020. I started working in lipidology here, and then focus was on LDL, but also on triglycerides and remnants showed here in red. Things happened then. There was the Nobel Prize to Brown and Goldstein for the LDL receptor, all the statin trials. And now today, the focus is 100% on lowering LDL cholesterol. 4S trials from Scandinavia was very important for starting this huge interest in LDL and statins. And then came HDL. There was a lot of focus on HDL because of epidemiology. People suddenly thought that HDL was more important than remnants and triglycerides. But then came genetics and failed HDL trials. And I think today, clinically, you should not look at HDL so much anymore. You should rather look at remnants and triglycerides. And then Lp(a) is now also becoming more and more clinically relevant. So when I simplify, try to make people understand that, then is the bad guy is LDL, remnants triglycerides is the ugly guy, and Lp(a) is the genetic guy, just like the movie The Good, the Bad, and the Ugly, American movie. What used to be the good guy probably should just be the innocent. HDL is not so important for cardiovascular disease. The latest European guidelines 2019 also talks about hypertriglyceridemia. And what is hypertriglyceridemia? Here's normal plasma where you can have high LDL, and then you will have high cardiovascular disease risk. You could also have high lipoprotein(a). When you have turbid plasma, this is because remnants and triglycerides are high, and then you have very high cardiovascular disease risk. And finally, there's this odd case with chylomicronemia, where you have triglycerides here, maybe 100 millimoles per liter, which is like more than 90,000 milligram per deciliter. Then you have very high risk of pancreatitis. This is really rare. This is very common for cardiovascular disease. So clinically, what we usually do when we take a lipid profile, we make plasma total cholesterol, which encompasses all these four fractions. We take plasma triglycerides, which is all these four fractions, but of course, mainly the triglyceride lipoproteins. And then we measure HDL cholesterol directly and LDL cholesterol directly. Lp(a) should also be measured, but note Lp(a) cholesterol is part of LDL cholesterol. And then finally, the fourth fraction, remnant cholesterol. I prefer, rather than just looking at plasma triglycerides, to actually calculate remnant cholesterol to better understand you have HDL cholesterol, LDL cholesterol, and remnant cholesterol. This is total cholesterol minus LDL cholesterol minus HDL cholesterol. Guidelines and many people also focus on pooling all these together as non-HDL cholesterol or just measuring apolipoprotein B. Should we do non-fasting or fasting lipid profiles? Here's tried to show that for a normal situation, people would eat some breakfast and then maybe a snack in the before lunch. Then they have lunch. Then they maybe have something in the afternoon. Then they have dinner and maybe a snack while watching TV or something else or a movie. And fasting is really if you have not eaten for 8 hours or more. So you can see it's probably only maybe an hour before you get breakfast that you're really fasting. So this is unphysiologically to fast. So to use non-fasting lipid profiles, in my point of view, is evidence-driven, while it is belief-driven to use fasting. Here you force people to fast for several hours before they have a blood sample. Who has endorsed non-fasting lipid profiles? We did early on in my little country, Denmark, in 2019. Then the American Heart Association already in 2011 endorsed non-fasting lipid profiles. Then there's the NICE guidelines from the UK 2014. There's from the US, this VA DOD also enforced it. And then we had a consensus paper in 2016 from Europe that also endorsed the use non-fasting lipid profiles. There's Canadian guidelines. There's the main European guidelines back in 2016. There's from Brazil, and there's the latest ACC or Endocrine Society in America. They also endorse it. And finally now, the very latest American Heart Association, American College of Cardiology, and the European ESC, they also now say, let's use non-fasting lipid profiles widely. The only thing that really changes is illustrated here is the fasting situation, and then up to 7 to 8 hours after fasting. What is the levels of plasma triglycerides. This is in 84,000 individuals from what's called the Copenhagen General Population Study. And you can see the average just goes up very little, 0.3 millimoles per liter in the non-fasting 3 to 4 hours after a fasting meal. And maybe this is even better to capture this because this better illustrates the risk. And correspondingly, remnant cholesterol goes up a little, not very much. Non-fasting triglycerides is a very, very important risk factor for cardiovascular disease. This is shown here from data from our 2 Copenhagen studies, Copenhagen City Heart Study, Copenhagen General Population Study, with 96,000 individuals and 3,300 myocardial infarction events. They are 99.5% correct, validated. And we followed people for up to 30, 40 years. And you can see a single measurement of non-fasting plasma triglycerides. If you have less than 1 to up to more than 6 to 7, the hazard ratio for myocardial infarction goes up to 5-fold from just a single high plasma triglycerides. The guidelines, what are their recommendations about treatment of patients with hypertriglyceridemia? Well, they say, and I 100% fully agree, that statin treatment is recommended as the first drug of choice for reducing cardiovascular disease risk in high-risk individuals with hypertriglyceridemia, triglycerides more than 2.3 millimoles per liter or more than 200 milligrams per deciliter. Then there's, with the new reducer trial that we probably will hear more about from Cosray, in high-risk patients with triglycerides between 1.5 and 5.6 millimoles per liter, 135 to 499 milligrams per liter, despite statin treatment, one can consider icosapent ethyl 4 grams daily in combination with the statin. And then there's also recommendations about using fibrate, fenofibrate or bezafibrate for primary prevention patients with an LDL cholesterol goal and still a triglycerides above 200 milligrams per liter and 2.3 millimoles per liter. And in high-risk patients who are at LDL goals, but again with the same high triglycerides, could be considered in combination with the statin therapy. I would like to draw your attention to familial hypochondria. This is extremely under-recognized and undertreated in the world. So the latest European guidelines, they say in primary prevention for individuals with familial hypochondria at very high risk, an LDL cholesterol reduction of 50% from baseline and an LDL cholesterol goal of less than 1.4 should be considered. What is familial hypochondria? Well, it's a dominant inherited disease killing the most people in the world. And it is, as I said, largely unrecognized, undiagnosed, and untreated. Cardiovascular disease in familial hypochondria is 100% preventable if you use statins. It's very simple to diagnose, very simple to treat. So heterozygous FH in the general population, roughly 1 in 250 is what we believe should be there. You get a gene both from your mom and your dad, so that means the allele frequency is 1 in 500, and therefore homozygous, here a very extreme case, is 1 in 250,000. FH, you have mutations in the LDL receptor, apolipoprotein B, so the LDL receptor is here in the liver, connected with LDL. ApoB is the protein on the LDL, and PCSK9 that recycles the LDL receptor. Then you have a liver with only 50% functional LDL receptors, very high LDL cholesterol. Most important are the LDL receptor mutation, accounting for more than 95%, leading to premature atherosclerosis and coronary heart disease, myocardial infarction, and angina pectoris. Clinical signs that you most should look for are these tendon thangiomas in the extensor tendons of the hands, and then the Achilles tendon, while these two are not pathognomonic for familial hypochondria. Here's an important figure trying to show you as age go up, what is the cumulative LDL cholesterol burden, meaning how much cholesterol does your arteries see? And if you're a normal person living in an affluent country, you can see that as years go by, you have more and more cholesterol exposed to your arterial wall. And by age 55, then you have risk of coronary heart disease. If you're a woman, maybe you can take a little more cholesterol. If you smoke, hypertension, diabetes, high triglyceride, low HDL, or high LDL, you can take less LDL cholesterol. But then if you're lucky enough to be heterozygous FH, you reach this target for coronary heart disease already age 35. And if you're homozygous, already at 12 and a half years. So here, untreated, these will be kids that have coronary heart disease and die before age 50. Untreated heterozygous will have chronic heart disease before age 55, 60 in men and women. But if you start statin early on, you can actually change this curve. So if you have FH, start statin as early as possible. Also important is to make a family tree. Here's an index patients, and then you want to look at what about the kids. Here's 2 kids that have FH, and for the parents, it was the mother that had the FH, the round symbol, the square symbol is the male. Measure Lp(a) once in all. This is a new recommendation from the European guidelines. So they say everybody should have Lp(a) to find those with the highest levels because they have really high risk, similar to familial hypochondria. Lipoprotein(a), as I said, LDL-like particle with ApoA on it. You have both high Lp(a) and low crinkle 4 type 2. They are causally related to atherosclerotic stenosis, myocardial infarction, and aortic stenosis. 80 to 90% is genetically determined, and this is from genetic evidence, these causalities. Here, back to back in this paper together with Cosray, published in the Nature Review Cardiology in 2018, we, based on the Copenhagen General Population Study, back to back in the same individuals compared an increase in LDL cholesterol, 1 millimole, 39 milligram per deciliter, with the same increase in remnant cholesterol, with the same increase in Lp(a). And as you can see from the observational evidence, that the risk for LDL is like this. For myocardial infarction, it's even higher for remnant cholesterol and yet higher for Lp(a) cholesterol. I'm not saying that Lp(a) cholesterol is what causes it, but just pointing at these 3 fractions, each have independent risk when adjusted for each other. And the genetic evidence here on the right side showed that they are all causally related and they are all independent of each other. I will finish off by just showing some new data published last year in The Lancet together with Martin Mortensen again, where it seems that most guidelines would sort of like stop advising statin therapy about age 70, 75. So we tried to look at what is the importance of high LDL cholesterol in the elderly. So in the Copenhagen General Population Study, we looked at the 20 to 49, the 50 to 59, the 60 to 69, the 70 to 79, and the 80 to 100-year-olds. And what is the hazard ratio per 1 millimole higher LDL cholesterol for myocardial infarction? As you can see, the very young ones dominated by FH have very high risk, but all the other age groups, including those aged 80 to 100, had the same risk of myocardial infarction for the same increase in LDL cholesterol, 1 millimole. This means as the risk of cardiovascular disease goes up, then if you look at the estimated events per 1,000 person years per 1 millimole increase in LDL cholesterol, then the risk is much higher in the 80 to 100 years olds, and again, second highest in the 70 to 79 years old than in younger age groups. I'm not saying that it's not important in younger age groups, I'm just saying that it's much more important in the elderly. Therefore, we estimated what's the number needed to treat in 5 years to prevent 1 atherosclerotic cardiovascular disease event. If you look at the overall population by giving statins to everybody, then for the 80 to 100 years old, you would need to treat very few to prevent events, much fewer than in younger age groups. And if you only look at the ones that were statin eligible according to European guidelines, again, similar picture, you would treat much fewer than for the younger age group if you choose to give statins to the elderly. Here's just finally a comparison between 4 major guidelines, the UK and NICE guidelines, the Canadian guidelines, the European guidelines, and the US guidelines. If you have secondary prevention for atherosclerotic cardiovascular disease presence, focuses on LDL cholesterol. Bring LDL down. But the Canadian guidelines and the European guidelines also said you also should make sure to get non-HDL cholesterol down, meaning that you also focus on the triglyceride lipoproteins, and the same, you should also get ApoB down. For primary prevention and familial hypochondria, the focus, of course, is only on LDL. It is an LDL disease. And then there's other primary prevention based on absolute 10-year risk or based on having diabetes or chronic kidney disease. Again, focuses on LDL, but in addition, in the Canadian and the European guidelines, also bring down non-HDL cholesterol and ApoB to certain targets. So my final slide is just summing up that when you want to risk stratify, it is most important to look at LDL cholesterol that causes atherosclerosis and atherosclerotic cardiovascular disease. But likewise, you must also evaluate high triglycerides or remnant cholesterol and also lipoprotein(a) to get the full picture of atherosclerotic cardiovascular disease risk prediction. Thank you so much for your attention.
Thank you very much, Professor Borg, for a very lucid lecture, very clear. Thank you very much. We'll leave the questions to the end. We'll move on to Professor Kaushik-Ray, who's a Professor of Public Health and the Deputy Director of the Imperial College Clinical Trials Unit and Head of the Commercial Trials within the Department of Public Health and Primary Care, School of Public Health, Imperial College London. He's a consultant cardiologist and the Chief Clinical Officer and Head of Trials for Discover Now, as well as an NIHR ARC National Lead of Cardiovascular Disease. His research has focused on the prevention of coronary artery disease with a focus on lipids, diabetes, biomarkers, and risk prediction. We're lucky enough to have him for 2 lectures. The first lecture will be on when to consider pharmacological treatment in risk management, what the evidence is, and the second is on non-statin therapies. Thank you very much, Professor Ray. We're looking forward to your talks.
Great, thank you, Sarah. Just find my slides. Okay, so we've heard a beautiful talk from Professor Nordahl already setting the scene for primary prevention. So I'm going to add a little bit more to that. There'll be a little bit of overlap, but hopefully I can give additional insights or a different take, and where necessary, certainly reinforce some of those important points. So remember, there is a real challenge sometimes when we think about pharmacological treatments, because we often actually have this kind of knee-jerk response to look at isolated risk factors instead of thinking about risk. Everything that we do comes down to some assessment of risk, and that's really what you're trying to prevent. You're trying to prolong quality of life and reduce deaths from prematurely, in particular, from cardiovascular diseases. So these are a list of my disclosures. And let's start with a case. So here's a 55-year-old male in a low-risk country, ex-smoker, overweight, blood pressure, reasonable, not ideal, but maybe reasonable. His LDL is on the higher side, but certainly not in the FH range. And his HDL cholesterol is low. And to put this into context, the Western average for a white male is 1.24. So this person is about 1 standard deviation lower than an average white male. Now, the question also becomes, is this partly due to the fact that his BMI is high, and that's the reason his HDL is low, or there could be a genetic component? If there is a genetic component, then this person probably has a longer exposure. Now, with a little bit more imaging, coronary artery calcium scoring, as you heard in the previous talk, is very important and very useful. And it's one of those things that actually helps to reclassify about 24% of patients into correct risk categories. So this means people who you would incorrectly assess as being at low risk would now be reclassified into a high risk group. And similarly, people based on maybe age or other variables, you would classify as high risk, correctly being reclassified into low risk individuals. And this is better than any biomarker, whether that's CRP, whether that is NT-proBNP or anything else. So a CAC score of 740 is incredibly high. And this patient was started on statins, ezetimibe, LDL and lowering therapies effectively in combination. And his LDL came down by more than 50%, down to 1.6 millimoles. But the question now is this an acceptable level of LDL for a 55-year-old, considering I've missed about 50 years of, well, let's say 30 years of potential treatment. So his gene environment interaction is such that his CAT score is really very high in a 55-year-old. Now, the other thing that came out during investigation is that his lipoprotein little a is incredibly high, one of the highest I've seen, 440 nanomoles per liter. We had a discussion about what to do next, and he can afford monoclonals. This, with levels like this under NICE, this would not be reimbursed, and we went on to monoclonals. Now, his LDL recently has come back as 0. I'm not particularly concerned about that, because we know that with the conventional assays that we actually have, that they are at the level of detection. So his real LDL is probably of the order of about 0.2, 0.3, 0.4. His HDL cholesterol with a bit of weight loss has gone up. So his HDL-C is 1.2, his non-HDL is actually 0.6. So his good cholesterol, or his good particles, are about twice as high as his atherogenic lipoproteins. Now, interestingly, with the MABs, and that was also one of the reasons for giving him a monoclonal, on average, monoclonals only reduce LPA by about 25 to 28%. He'd actually got the biggest reduction I'd seen, so almost 50%. So his LPA has come down to about 230. So in theory, if you basically look at his 10-year predicted risk on the basis of the coronary artery calcium score, and then looking at how much reduction we would get based on the absolute reduction in LDL and factor in the absolute reduction in LPA, his theoretical 10-year risk has come down from about 20% down to about 3.8%. If we now look at another case, here is a female, and here is, she's a non-smoker. A BMI is on the higher side, and there's no family history of premature coronary artery disease. Her blood pressure is 130. Now, about 2 years ago, she was diagnosed with type 2 diabetes, but no evidence of microvascular disease. She was started on atorvastatin 20 milligrams. That's the standard starting regimen for somebody like this in my country. And her LDL basically has come down to about 2.2 millimoles per liter. So everybody on average seems to feel quite happy. You're 70, 65, no other obvious risk factors. Yes, you've got diabetes, but it's relatively short duration, no evidence of microvascular disease, so maybe I shouldn't worry so much about it. But she then presents with an acute myocardial infarction, and she undergoes an angioplasty to a left anterior descending artery. Ejection fraction's good. She's put onto an ACE inhibitor and a beta blocker, dual antiplatelet therapy, and her statin dose is increased now to 80 milligrams. But remember that when you basically double the dose of statin, you're only getting another 6% further lowering. So, we have this magic of, I'm using high intensity statins because I've gone from 20 milligrams now to 80 milligrams, but the LDL has only come down from about 2.2 to about 2.02 millimoles per liter. Her triglycerides are 1.2 and her HDL is 1.4. Now, if you followed those, that nice example in the previous talk, she is above goal, and she would certainly warrant using ezetimibe, which might give you 20 to 25% further lowering. But remember, because benefit is related to absolute reduction in LDL, the amount of reduction she's going to get is going to be about 0.4 or so millimoles. So the benefit that she's getting in addition to what she's on already is probably going to be about 10% further lowering. So if I want to maximize her benefit, there might need to be a consideration, for example, for a monoclonal and a monoclonal early, because that might achieve a further 1 millimole lowering of LDL cholesterol. So this is really a reminder that don't look at risk factors in isolation. Yes, it's useful to look at risk or certain conditions because they might be the main things that are driving up your risk of future cardiovascular disease. But what you're interested in are predictors and parameters that give you some idea of what 10-year risk is going to be. So We look on the right-hand side at 3-point MACE. So this is typically cardiovascular death, non-fatal MI or stroke, or you can add in revascularization. Event rates go up, but perhaps it's cleaner to look at the natural history and look at CV death, non-fatal MI and stroke. So who has the highest risk? Well, if I've had an acute event in the last year, we know that that early period, that first year, carries the greatest risk. So I've self-selected myself as somebody who's got a very high risk over that next year. If I survive that period and I've had a previous history of an acute event, my lifetime risk is going to be pretty high, but it's not as high as in that first period. So my event rate is going to be a little bit lower, but I'm still going to be higher than other groups. And maybe I had my event on the basis of, you know, if you'd taken a history from me the week before my MI, you might have said, you know, you're at moderate risk or low risk. So the big driver here is the fact that these people have self-identified as individuals where their genetics and their previous history, their lifestyle is such to be driving this high event rate. There are people who have stable presentations, and you might think that, well, they must have the same event rate. They don't necessarily. And part of the reason behind this is these are people that probably have some protective factors. And even though they are progressing, they have progressed with more stable disease and not an acute thrombotic plaque, unstable or unstable event. So they're a little bit there, they're below the acute group, but they're higher than people that have just risk factors. So this is really the challenge that we have when we try and have these individual consultations in our weekly clinical practice. And this, for me, of all the cholesterol treatment, probably the most cited set of papers are in prevention, are the cholesterol treatment trialist papers. The third iteration, the third paper in 2012, for me is the most informative because it doesn't separate people by primary and secondary prevention necessarily. It looks at 10-year risk. And here, as you've heard already nicely said, that there is no such thing as a normal LDL. The lower your LDL is compared to the person next to you, the lower your risk of events. But this benefit really depends upon what your starting level of risk is. So if you look at the number of events prevented, and I look at 1,000 events or 1,000 people at risk, and I look at people with an annual risk of less than 1%, and this is looking at essentially major vascular events and deaths are on the right. Essentially, if I have an annualized risk of less than 1%, if I achieve a 1 millimole lowering, so about 38 mg per deciliter lowering an LDL, I will prevent 6 events. But if I achieve a bigger reduction, so 100 mg per deciliter or 2.5 millimoles, I'm going to prevent twice as many events, so 12 events. But because the starting level of risk is so low, the gain is going to be small. So if you like, if I overtreat this patient population by recommending very or large reductions in LDL cholesterol, the gain's going to be small. And if my treatment is really expensive, then maybe there isn't much of a return here. But we can't argue that lower is not better because clearly it is better. But if I don't have much risk to start with, the gain's going to be small. Now, on the other hand, if I take a population at the back row, with an annual risk of 6% or more, because I have such risk, whatever you throw at me is going to be very effective. So if I reduce LDL by 1 millimole, 38 mg per deciliter, instead of 6 events, I'm going to now prevent 61 events. So I've got a huge gain, got a bigger bang for my buck from that first intervention. But because my event rate is so high, you would ideally not want to leave me with just 1 millimole reduction in LDL. So at a population level, if I reduce that population risk by another 100 milligrams per deciliter, then instead of 61 events being prevented, I'm going to prevent 142 events. So this really underlies and underpins our approach to prevention. You don't want to overtreat low risk, but you don't want to undertreat high risk individuals. So in the ESC/EAS guidelines, whether you agree they're perfect or not, there is at least an attempt to try and put people into those categories. So very high risk, if you look at that first graph I was showing you, are people with established cardiovascular disease, however that is, whether that is imaging with an acute event or so forth. Now, you can get into this group by in a primary prevention category. So as you'll see in a second, with diabetes. Now, with diabetes, you need either evidence of end organ damage or 3 major additional risk factors, or a very long duration of diabetes. Now, you could also get there with an isolated risk factor involving the kidneys, but the level of renal dysfunction you're going to need is quite marked. So an EGFR less than 30, or you basically, if you don't fall into these categories, you basically have small amounts and combinations of different things that put your 10-year risk of dying above 10%, or you've got familial hypercholesterolemia and another factor. And if you then move to the different risk categories, there are no patients now in these categories with established disease. So they're all some form of primary prevention. But these categories really reflect some estimate of 10-year risk. So you looked at global risk, your 10-year risk of dying would be somewhere between 5 and 10%. But then your renal function to get you into this category is not now that severe group. It's now an EGFR between 30 to 59, for example. You can get here with familial hypercholesterolemia on its own. You don't need a risk factor. And you can get here with an extreme elevation in an isolated risk factor like LDL or blood pressure, for example. But with diabetes now, we've kind of made the entry criteria to this group less stringent. So now you're somewhere between 10 and 20 years, for example, because you've got smaller or shorter duration of diabetes. You can get here without evidence of end organ damage, for example. And you can go through the same example looking at moderate risk, which now brings in younger patients with diabetes into play, and you'll see why in a second. And your 10-year score risk is between 1 and 5, and the low risk group essentially is just made up of score risk of less than 1%. Imaging, I think, potentially can be really quite useful. Now, the way we tend to use this often is to make that first decision. So you can see, for example, the recommendations about the use of carotid intermediate thickness, ultrasound. And so what if you or coronary artery calcium score? So what if I have a 45-year-old patient, for example, who, because they're young, they just haven't, but they've got extremes of risk factors. Now, you might have a conversation with them and they might accept that actually early treatment is better than late treatment, and they go on to treatment. On the other hand, they might say, I really don't like the idea of pills, doctor. So I want to wait and watch. So what do? Do you just leave them to have their event? Well, one approach might be to reassess. We need to look at the change, for example, between today and maybe in 5 years. And there are people that have maybe more rapid progression that you can then have a conversation about more intensive treatment, or in some cases, early intervention and treatment, because they've kind of neglected these risk factors, but they don't want treatment. But you might be able to visualize, say, look, actually, you are now going from 0 CAT, you are now at 100 within 5 years. Now would be a good time, because now you're still fairly young and we might be able to avert your course. So let's take a couple of examples. So we don't consider diabetes as being a CHD risk equivalent. The early data from Hafner essentially included people with 14, 15 years of diabetes. We didn't appreciate duration of exposure as being an important factor. So now we've got data in primary prevention, and this was one of the main papers that we wrote that basically changed the guidelines in the European Society of Cardiology. And so, for example, what I've done here is just to show you, if you had one manifestation of microvascular disease, so the focus was microvascular disease, each of these on its own can increase your risk by around about 30%. And it doesn't matter which one they have. So these are interchangeable. And it could be argued that these are just really a manifestation of duration of diabetes. And they're not, because when you take duration of diabetes and microvascular disease into account, duration of diabetes actually drops out. So actually, the biggest predictor, for example, of risk in this patient group tended to be the presence or absence of microvascular disease. And these are just some of the other things that contribute to the model. So you can look at a number of different things. You can look at the absence of microvascular disease and just adding them together, 1, 2, or 3 manifestations. And you can look at 3-point MACE, and these are the number of events that occur. So your 10-year risk, for example, of cardiovascular disease, if you have 3 manifestations of microvascular disease, is 22%. Your 10-year risk, if you have none of these, is 5%. So each one of these gains you another 5%. And if you looked at, for example, heart failure hospitalization, and we've got treatments, for example, like SGLT2 inhibitors for primary prevention of heart failure, for example, the same relationship with the number of manifestations of microvascular disease is observed. And the same is true of deaths from cardiovascular disease. So this is really useful as a tool. You'd actually correctly reclassify patients by about 10% using this, if you add this to Framingham or any other tool. So you can look at how these different things stack up. So again, there's this multivariable model really just showing you the number of different manifestations of microvascular disease, things like blood pressure, LDL cholesterol, and you can see what the standard deviations are for each of these. This is a 13 millimeter of mercury systolic blood pressure, which is about a 1 millimole higher LDL cholesterol. And why are we interested in this? Well, the same is true of the CTT analysis. We have different cut points of HbA1c, BP, and LDL. These were old goals for primary prevention that were recommended. But basically, if I don't have microvascular disease and my patient is apparently at all of these goals or at none of these goals, there is an increase in risk, but the increase in risk is small because the risk is low to start with. But for each manifestation of microvascular disease, so going from 0 to 3, it becomes really important to control all of these people to goal, because the person, for example, with 3 manifestations of microvascular disease, I need to not just control their LDL, I need to control their blood pressure, I also need to control their HbA1c. So this concept of global risk is essential. Another key thing that you might want to look at is the age at which you make a diagnosis. Because essentially, if you're thinking of life years gained, younger patients will have very low short-term risk. And this is one of the flaws with our current risk tools. And older patients will inevitably always have high risk. But if we want to preserve those working years, then one way of thinking about it is, what is my lifetime risk? So one way of thinking about a patient with diabetes is that, look, I'm going to lose half a decade of life. Half of those life years are going to be lost from vascular disease, whether I'm male or female. So in older patients, it doesn't make sense to try and look at life years gained, because there is nothing you're going to be able to do that's really going to gain back, let's say, half a decade or so of life. The younger people, it's a really good way of trying to engage them. And if you have diabetes with already established vascular disease and you're aged 40, you are going to lose a decade and a half. So we need to claw those years back, which means this patient aged 40 has to be treated way more aggressively than somebody aged, let's say, 85 who's had diabetes and just recently diagnosed and happens to have had a heart attack, if we're thinking about life years gained. Now, do treatments work? Absolutely. So a statin, remember, people with diabetes don't have particularly elevated cholesterol levels. So statins work. These are 2 different drugs in 2 different trials showing complementary results. And they actually give you similar percentage reductions in LDL. Atorvastatin 10 on the left, simvastatin 40 on the right. about a 1/3 to 1/4 lowering of the risk of cardiovascular events. So if some statin is good, is more better. And this is data from the TNT trial. Of course, this is a population with established cardiovascular disease, but again, it shows that greater reductions in LDL in this group will actually translate into greater benefit when you have diabetes. So let's move to looking at LDL cholesterol per se. There is a major reason that we don't use for FH and for very high cholesterols a risk calculator. And we didn't really have a lot of good data to try and tease this out. So what one of my team, Antonia Vallejo-Vaz, did is we went to reanalyze the WASCOPS data. So WASCOPS did have about 1,000 people with some evidence of atherosclerotic disease. They hadn't had an MI, but there was some evidence on an ECG, a TIA, or claudication. So we isolated a population that was pure primary prevention, and we broke them down by LDL cholesterol above and below 130. And because we've got this extended open label extension period and linked data and follow-up, we could assess the benefits long-term. So the first thing we did was we looked at the population with an LDL above 190. And if you were to basically put them into a risk calculator, so this is the ACC-AHA, the old called cohorts equation, which recommends statins for anybody with a 10-year risk above 7.5%. 2/3 would have had a predicted risk below 7.5%. But what you can see is that the observed risk over 5 years, not 10 years, was already 7.5%, not predicted, observed in the placebo group. And that could be reduced quite markedly from 7.5% to 4.8. In those below 190, the 5-year risk was 5.7%, and that came down to 4.5. So the observed risk is already much, much higher than what you would predict. So don't use risk calculators, because you want to change that long-term trajectory through early interventions and early LDL lowering. Now, remember in WASCOPS, they used a fairly weak statin, pravastatin 40. And people have argued that there's not much benefit in mortality, but you need to do these trials for long enough to follow up these benefits. And in primary prevention, your risk of dying is actually quite low over 5 years. So to look at the benefits of treatment, you actually have to follow people up for much, much longer. So in a primary prevention population, what you can see is that you've got about a 28% reduction in risk of dying from coronary heart disease. There's actually an 18% all-cause mortality reduction, because as you get older, having a higher LDL is more likely to expose you to vascular diseases, as you saw nicely in the previous presentation. It was on the basis of that that all of these boxes that you see as red were changed in clinical guidelines, because until that paper, the recommendation was still to do risk classification, even though your LDL could be above 4.9. So put people onto pharmacological treatment. Don't mess around with just diet and lifestyle. Start putting them onto treatment in addition. So cumulative exposure is a big problem. The average age of diagnosis of FH is here, 40 or 50. Now, you basically are already on this trajectory. These are people with FH versus non-FH patients. Because of this issue about cumulative exposure, the curves continue to diverge much, much more. This basically means if you make a diagnosis late, you will have to treat more aggressively. But conversely, it means that if we make a diagnosis early, we might be able to change the life course very simply through cholesterol lowering treatments. So this can be shown on this graph here. This is the average age, if you like, that most of us might develop cardiovascular disease. If you think about it, there may be in your destiny so-called cholesterol years. On the other hand, if you have an LDL receptor mutation, heterozygote, you'll bring that further forward because you're exposing yourself to higher levels from birth. And if you're unfortunate, as is often the case particularly in some regions of the world where consanguineous marriages are much more common, you will have 2 abnormal genes, and therefore you will get to your cholesterol threshold much earlier, before the first 20 years of life. And often that's fatal. So that's what we have to try and consider. This paper, I think, is one of the most beautiful analyses that really takes into this concept of cumulative exposure really to its natural conclusion. So if you take a family history in that pedigree that was shown in the previous talk, the history that you'd get is grandfather died suddenly, maybe aged 55, 60. The father had a myocardial infarction, but was fortunate to survive and got treated. But because we knew a little bit more about FH, we then started screening the kids. So what then happened? So if you look in this study at children and you look at their affected parents, and you look at FH and non-FH patients, you can see that between the affected individuals and siblings, there's a big difference in LDL cholesterol. And then, because we start treatment early, we bring the LDL down. Now, it's not perfect, but we've brought it down over 20 years, but we've done so early, before the age of 20. And in the non-affected individuals, cholesterol is going to go up as you age, but it's going to go up later. So those differences that you see, even though they're imperfect, reflect early or cumulative exposure. And so what you see is that with the children starting LDL cholesterol reduction early compared to their parents prevents many events, saves lives, if you look at survival on the right-hand side. So this is why early treatment is so important. We can think about imaging, we can think about all of those additional measures like lipoprotein(a) that often accompany these individuals with FH, but we need to think also about early treatment. I won't go over these in much detail because they were already covered, and I'll maybe cover them in the therapies. But essentially, our goal is to try and think about risk, who is at most risk, look at age as well, particularly if they are younger, and remember that risk is heterogeneous. So you need as much information as possible. Don't undertreat people, but don't overtreat them earlier. And this fits into the cost effectiveness. There are many nuances of risk assessment, including those people with diabetes, looking at additional factors like microvascular disease, and for FH in particular, the timing of that diagnosis. And LDL lowering per se can be mathematically quantified, and it doesn't matter how you lower it. And the reason we've got these steps is that largely because of cost rather than anything else. Duration of therapy is rarely factored in, but the basic rule of thumb is for those at highest risk, you need the most treatment, and you will probably need combination therapy because you can't get to those lower goals without it. So I'll stop there and maybe move on to my second talk.
Yes, please.
Okay. So my second talk is on non-statin therapies and where they fit in. So all of the guidelines, so these are my list of disclosures again. So all of the guidelines really start with statins as first-line treatment. And the reason for that is that we know from the cholesterol treatment trialists, nature really does not care what is driving your risk. If you lower LDL by about 1 millimole or 38 milligrams per deciliter, you will reduce risk by 1/5. Doesn't matter whether it's diabetes that's driving your risk, or whether it's a high LDL that's driving your risk, or whether it's hypertension, or you've got established cardiovascular disease, or whether it's CKD3 that's driving it. So we need to think about other particles as well, and you've seen this to some extent, so I'll be brief perhaps with this. Essentially, I think as we move forward, we will separate, although LDL is clearly the something that we are very convenient, that we are used to, that's been conveniently used in many guidelines. For many individuals, it will inadequately capture risk. So the importance of triglyceride-rich lipoproteins, and so when you see those patients with a high triglyceride, the trigger in your mind should be not to look at LDL, but to look at either ApoB or non-HDL cholesterol. Because if you don't, you are going to underestimate risk. So you could have a patient with a high non-HDL who's got very high levels of LDL cholesterol. That person's most of their ApoB lipoproteins are in the form of LDL. So LDL and non-HDL are fairly close together. But there's another individual maybe with the same non-HDL, but now it's split between the LDL particle and these additional particles. Now that person's risk is equally high. But if you don't look at these other parameters and only look at the LDL, you will underestimate the risk. And as you've heard already, LPA is incredibly important as well. And we're all working towards developing therapies that target that. So if I need to move away from LDL, what are my equivalent goals? Well, whatever your LDL goal is, your non-HDL goal is fairly easy to remember. It's about 30 milligrams per deciliter higher. So if I'm aiming for those new, very high risk goals of less than 55, my equivalent non-HDL goal would be 85. If I'm aiming for an LDL below 70, my equivalent non-HDL goal would be 100. If I'm aiming for an LDL below 100, my non-HDL goal would be 130. The equivalent ApoB goals would be 65, 80, and 100 milligrams per deciliter. So we don't have specific goals for triglycerides as such, but we use triglycerides as a marker or a measure of identifying those people who are just going to be at that higher risk, even when I've done all of those first things like statin therapy. We've seen this already, and I think that we are now ready to move on from this, and I'll tell you why. So this rationale for the use of first statins and then ezetimibe, I think now becomes flawed. And the reason it becomes flawed is that ezetimibe is generically available. I think that it's underused. So if you look in UK general practice populations, it's used in about 3% of our patients. In registries, it's used in about 9% of patients. And this stepwise iteration is a disadvantage. And I think what we should probably be doing is combining steps 1 and 2 together. If you collapse that and now not think about high intensity statins, because there's no real downside, is think about high intensity lipid lowering treatment, because these are generic, then actually we're going to get more and more people to goal. And it will be easier because there's only one more step to consider, and that's the PCSK9 inhibitors for those particularly at very high risk who don't get to goal. Now, if you look at the data from the Da Vinci registry that we conducted, one really important thing between 2016 and 2019 is that 3 of the risk categories, the goals moved to become more intensive based on data that lower was better, there's no threshold. But to do that mathematically, you have to use more combination therapy because the baseline has not changed. We have artificially moved those goals. There's this additional variable, which is this 50% reduction. And the only reason that is there, it's to try and encourage you not to use homeopathic doses of statins, first of all, because what we often do as physicians is we'll start on the lowest dose and there's a reduction, but we don't really assess risk properly. So we forget to, increase the treatment because the patient doesn't tell me, hey, my 10-year risk is 25% still, because it's an asymptomatic condition until you have your heart attack. So this was really a crude attempt to encourage doctors to use more potent doses of statins up front in the hope that that's going to achieve improvements in public health. But at the same time, having done that, to then look at those goals. So that's how these fit in. Now, when you look at the data for Da Vinci, and this is true all around the world, unlike blood pressure, where our colleagues have been using combination therapy for many years. People don't talk about high-intensity beta blockers, high-intensity calcium antagonists. They use combination therapy. So in Europe and many parts of the world, our approach to lipid lowering is monotherapy. 84% is monotherapy. Now, it's great that a good chunk of that, 52%, is moderate intensity and 28% is high intensity. And there isn't much use of just low intensity statins on its own. But combination therapy with a generic drug is only 9%, and use of MAB lower still. So what's the impact of monotherapy-based approaches? So for risk-based goal attainment, when the goal was easy to use, 1 in 2 patients would get to goal, 54%. But with those new goals, in the period that we conducted Da Vinci, you would only get 1 in 3 patients to goal, meaning you will have to use much more combination therapy, particularly when you are trying to achieve those lower goals. That means people with established cardiovascular disease, FH with an additional risk factor, those people with more severe renal dysfunction, and those people with diabetes and microvascular disease, for example. So what about ezetimibe? Ezetimibe works through targeting a receptor called NCP1L1. This sits on the brush border of the intestines. And so this basically stops this transport of cholesterol into the lymph. And so you get less in the way of chylomicrons. And so we can actually interfere with that step. So now if you reduce the delivery of these particles to the liver, the net effect of that from the liver is now to produce more LDL receptors. If I produce more LDL receptors, blood levels are going to fall. So when you add in ezetimibe, you get somewhere between 20 and 25% lowering of LDL cholesterol, either as monotherapy or when you add it to a statin. Now, the problem with ezetimibe is, I think, a bad press in that routinely we only use this when we think about statin intolerant patients. So we don't routinely think about it as combination therapy, but it's actually quite an effective treatment. Remember, benefit comes not from percentage reduction, but absolute reduction in LDL. So if I have a patient with an LDL of 120, I'm going to get a big absolute reduction, so a big cardiovascular benefit. Now, there is cardiovascular benefit with ezetimibe as an add-on to statins, and that's data, for example, from the Improve It study. And you might look at this and say, oh, the benefit was really small, but it's not. Because your control group already had an LDL of 69, what am I going to get if I add in ezetimibe? Well, you can do the maths. It's about a 15 to 18 milligrams per deciliter further reduction in LDL. And that's what drives benefit. So fortunately, the authors, when they did this study, because the absolute difference is small, I need to allow a longer period of time to see a benefit. So fortunately, that's what was done. And therefore, this supports the concept that it does not matter how you lower LDL. What matters is reducing it, preferably early, and maintaining it. But the amount of benefit that you get was exactly predicted mathematically from the cholesterol treatment trial, this collaboration. We now have another drug. We're waiting to see what the cardiovascular outcome trials will show. But basically, this drug works in the same pathway as statins, and it's called bempedoic acid. It works 2 steps up from statins in the cholesterol synthesis pathway. And the enzyme that it targets is something called ATP citrate lyase. Now, one really important difference between this and statins is that the drug is a prodrug. It needs to be converted into an active form. The enzyme that needs to convert to the active form is only found in the liver. And once converted from the prodrug to the active form, it can't leave the hepatocyte, meaning that for patients, for example, who often get statin-associated muscle symptoms or myalgia, or in rare cases, myopathy, because the enzyme doesn't exist in skeletal muscle, you aren't actually going to get this active drug being created in skeletal muscle. So it could be particularly good as a drug for people who are statin intolerant. The benefit being, this also works through the LDL receptor. Remember, when you give people a statin, what you do is by reducing intracellular cholesterol, you make the liver manufacture more LDL receptors. And this is what lowers cholesterol. Now, this has been tested in large phase 3 studies and is approved in many parts of the world. So let me take a step back. So because this drug is working in the same pathway as statins, the amount of statin you have on board matters to the efficacy of the drug. So if you basically take people on moderate or high intensity statins, so that was done in 2 of the trials, Harmony was the one I led, and then there was also Wisdom, the additional percentage reduction on top of a lot of statins is 18%, largely because you saturated that pathway. But if I have low dose or no dose of statin in the background, the average reduction I'm going to get is a further 25%. In LDL, you can get up to about 28% as monotherapy. Now, what do I do in clinical practice for patients who are statin intolerant? Normally, I give them ezetimibe. Well, bempedoic acid is available with as a combination pill, as a single tablet with ezetimibe, and the two together can give you almost 38%. The placebo-corrected difference is 38% compared to nothing. So there are patients who can't tolerate statins. If I was to use a combination of ezetimibe and bempedoic acid, I would be able to achieve about a 40% reduction in LDL cholesterol. So this is from a paper that you've already seen, and it's one of my favorite graphics because it really shows the concept of the LDL receptor and how important it is beautifully. So our current approach at the moment, our first line treatment, is with small molecules, and it's statins, could be bempedoic acid, and ezetimibe indirectly increases the manufacture of the LDL receptor. Now, I don't know if you wondered about when you double the dose of statin, why you only get about a 6% further lowering. Well, the liver produces a second protein called PCSK9. So even though we manufacture more LDL receptors, PCSK9 breaks down the LDL receptors. So what happens is, instead of the LDL receptor being recycled and doing its job again, if PCSK9 is present and bound to the LDL receptor, it's broken down. It therefore makes sense that if I use a drug that's targeting PCSK9 and either reducing the amount in blood or stopping PCSK9 binding to the LDL receptor, these LDL receptors that I'm manufacturing, I can now make them live longer. So it's a magic combination, if you like, to achieve an 80% or so reduction in LDL from the untreated state. Now, the current way that we have available to do this is with monoclonals. And this is basically an injectable therapy that binds free PCSK9. And if all of the free PCSK9 is bound, there's very little, if any, binding to the LDL receptor. An alternative way is to reduce the synthesis of PCSK9. Now, to do that, we can do that with an RNA-based therapy. It's like switching the tap off, because the majority of PCSK9 in blood comes from the liver. So think about blood levels of PCSK9, and you can imagine somebody sitting with a bucket. Now, the bucket, the MAB, could be small, meaning I can collect some of the PCSK9, but the bucket will overflow. So I'll get some reduction in LDL, but it won't be much, and it will bounce back up. If I use a bigger bucket, I catch more PCSK9. But if my bucket's not big enough, I'm going to have to replace it quite quickly, maybe in a few days, maybe in a week. If I use a bigger bucket, what I'm going to get is I'm going to collect the PCSK9, and I can leave it longer before I have to leave the kitchen, if you will, and replace and get a bigger bucket. So I can get a very stable reduction in LDL cholesterol. And we know that this translates into reduction in clinical events. So this is data, for example, from Fourier, basically showing you the addition of a PCSK9 inhibitor, in this case, evolocumab, on top of statins in stable coronary disease. The benefit was proportional to the duration of the studies. Actually, relatively short studies. The average was about just under 2 years. And then we have data from a second PCSK9 lowering therapy that adopted a slightly different approach of a treat to target. It was post-ACS, average about 2.4 months after an ACS event, also showing benefit and in this patient population. So again, we know that nature doesn't care how you lower LDL cholesterol. So in the future, how might we do this? Well, these RNA-based therapies, I think, offer a huge opportunity, which is convenience. And the reason for that are several-fold. But let me walk you through the differences. The two types of RNA-based approaches are one, antisense, again from the same review, and this works within the nucleus. So this is being tested for LPA lowering, but the downside of this is the dosing interval is probably going to be more frequent. It's monthly. This works inside the nucleus. It's a single strand of RNA that's matching like a Lego brick, matching the messenger RNA for the protein that you want to stop. And once found, an enzyme called RNase 8 breaks this down. Now, there's a second process which works in the cytoplasm that requires a double-stranded RNA, so you can mimic that with a drug. This is a natural process for which was a Nobel Prize awarded 15 years ago. And essentially, your body is switching off messages all the time. So your body picks up double-stranded RNA strands, and essentially, when there is a messenger RNA that it's targeting, that antisense strand guides it to that messenger RNA in the cytoplasm, and it breaks that down. And it's this thing here is called the RISC complex. So this is what gives it a long duration of action with any drug and this stability. This is why you've got a very efficient way, and it's like switching off a tap. So this has been tested in several phase 3 studies with a dosing interval. The first drug of its kind in this class is called inclisiran, dosing on day 1, day 90, and then 6 monthly thereafter. It's been studied in Orion 9, in heterozygous FH, Orion 10, in established cardiovascular disease, in Orion 11, in established cardiovascular disease and high-risk primary prevention. And if you pool all the data from the trials, what you can see is the peak effects are 55%. But what's more important is the area under the curve. So in this dosing period, this dosing interval, if you will, you could talk about annualized reductions in LDL of 52% with twice-a-year dosing or 6 monthly dosing. And that's important because one of our biggest challenges for population health is in order to achieve lower goals, I've already told you, you're going to need combination therapy. But the problem with combination therapy for our patients is that they have to take them and patients don't do what they're supposed to. So you can see that on this graph here, where we can look at what doctors do, which is the prescriptions, and what patients do. So high intensity prescribing in a fully adherent patient gives you a bigger percentage reduction. But if you look here, even when you and I as doctors do the right thing, if a patient is not fully adherent, they're only going to get a modest reduction in LDL. And in fact, a patient where we prescribe a low intensity treatment, but is fully adherent, might actually achieve a bigger percentage reduction. And in risk terms, that combination of adherence and prescribing not only tracks with LDL, but tracks exactly in the same way with risk. So from a population perspective, in the UK, for instance, looking at how we're prescribing and how patients behave in an ASCVD population basically means that there are 72 events occurring per 1,000 per year. If we had optimal prescribing and optimal adherence, this number could fall to 48. This means for 500,000 people, there would be 12,000 events prevented per year. So that's what population health kind of looks like. We need additional LDL lowering, but we need to have this maintained. Now, we can talk about atherogenic lipoproteins and LDL and ApoB, And this is a nice review that kind of summarizes some of this, where you can either reduce production or increase clearance. Most of our methods focus on clearance. But triglycerides, I've said to you already, and you've heard in the previous talk, are an important residual risk factor. They may be the main things that are driving your risk. So how are we going to target these? Well, we potentially could target synthesis with fibrates. And we believe to some extent that fish oils, particularly high-dose fish oils, could reduce triglyceride and improve outcomes. Well, I won't touch on Lp(a) because we don't have those outcome studies yet, but those are ongoing. But we do have some evidence for what to do in people with high triglycerides. So the first bit of evidence is that essentially, if you take people with high triglycerides, optimize the dose of your statin first, because we're interested in risk. And people with a high triglyceride will derive bigger absolute benefits when you optimize the dose of a statin. So that's the first thing you need to do. Now, the next thing you could do is consider a fibrate. We don't have really good compelling data. We have subgroups of pre-existing studies, and there's a clear difference between those people that don't have a triglyceride that's elevated, no benefits from fibrates, and those that do have high TG and a low HDL. This is still ongoing in a contemporary study called Prominent. But for those areas maybe where you don't have access to MABs after maximizing statin therapy, or you've just optimized the ezetimibe, it may be reasonable to consider a fibrate, particularly if the triglycerides are high, because you'll change atherogenic lipoproteins as well. This is a really important study, reduce it. It doesn't prove the triglyceride hypothesis, because even though it studied a population with high triglyceride levels, triglyceride changes were really small. However, what it did do is it gave you, because it was a large study with a long follow-up, it did give you a large clinical event reduction. There's a little bit of confusion about this, and we're uncertain if the comparator, the mineral oil, is artificially making these numbers look better than they are, because mineral oil can push up, for example, LDL, ApoB, push up C-reactive protein quite a lot. Now, whether that's a innocent bystander and an artifact, or it's causing harm, is uncertain. Recently, we published some analyses from the strength trial, which the overall study with a compound that contained DHA and EPA was neutral. And what we looked at were in the people that were treated with the combination therapy. We looked at the people with the highest achieved levels of EPA and highest DHA, and we found neither benefit nor harm. So it could be that these benefits are simply EPA specific, or it could be there is some contribution from the mineral comparator, and there is some uncertainty about this. So in summary, add-on non-statin therapies in particular are synergistic to statins in that most of them will work on improving clearance of atherogenic lipoproteins. So not just LDL lowering, but other ApoB containing lipoproteins. And you'll see, therefore, reductions in non-HDL and ApoB. Some of these agents are oral, but increasingly newer agents are injectable therapies with different advantages. Clearly potency, but potentially the opportunity for infrequent dosing, which offers convenience for things like adherence. Triglycerides are a great measure and marker of residual risk, but what we're really targeting is the ApoB particles in the non-HDL. And it's uncertain whether treatment A is better than treatment B, but I've tried to show you some of the options that are available. And there is, clinical equipoise. If you ask one person, they'll say, I'll look at this. If you ask another person, they'll say another. And without a head-to-head trial, there is no right or wrong answer. It's a gray area in medicines and art. In future, I think that there's one big bastion left in addition to the triglycerides, and that's being able to show definitively, not some of these indirect analyses that many of us have done, on LPA lowering with MABs, but specifically treatments that target and lower LPA by 80 or 90%, and then hopefully showing that that translates into reductions in the risk of clinical events. So I'm going to stop sharing now, and I'm happy to join my colleagues in Q&A. So thank you for listening.
Thank you very much for two fantastic talks. We've got a few questions on the chat, and I've got a few questions as well. So let's start off with the ones on the chat. Rada Atesh is asking what the maximum level of lowering of LDL can be. I assume she means safely reached. And I think, Professor Ray, you've already discussed this, but if you'd like to, if you don't mind, handle that as well.
You can't be too rich, you can't be too thin, and your LDL can't be too low.
Thanks. The next couple of questions are for Professor Jamal Kabi, and he's asking if a patient received a statin for 30 years, what is the potential gain in life in years? Assumably, that's where they start off, where their LDL is, but
yeah,
best case scenario.
It's not just, I'll be interested to know what Borg thinks actually, but you have to calculate it on the basis of baseline risk. So there will be gains that will be based on starting level of LDL. You can mathematically calculate relative benefit, but you need to know all the factors. You know, was the LPA high? Were they a smoker? If there's a family history, they've got more genetic vulnerability to the same exposures. So younger patients, though, will gain more life years than, you know, I mean, somebody age 95, there's not much you're going to be able to do to increase the life expectancy, quite frankly, no matter how much your LDL comes down. Borg, do you want to
I fully agree with that. But of course, if you had somebody getting statin for 30 years and there was a good reason for doing it, there's absolutely no reason not to keep on giving them if there's no side effect. And I presume taking it for 30 years, there will be no side effects. And as I showed you this one paper we had in the Lancet last November, the older the people, the more benefit from statins because the absolute risk is higher. So just keep on using it. That's my advice.
I guess what Professor Jamal Kabi was alluding to is there a magic figure? So a drop of X millimoles will give you a reduction of X per year. Sorry, Professor Jamal, if I'm quoting you, but I don't think there is an absolute figure.
No, and I think if I can add also there, fully agree with Professor Ray that when you get to the very high age, you're not aiming at having people live for a lot longer years, but you're aiming at having them be healthy until they die for maybe some other reason.
Yeah.
His next question is even more interesting. What would you say about tea or coffee having a favorable effect on lipid profile?
I don't know. I mean, the changes on lipid profile
are going
to be modest, right?
No, I wouldn't mind comment because I actually did a lot of studies genetically. There's a genetic variation that makes people drink more coffee and similarly more tea. But of course, this is particularly relevant in the UK where they drink tea like the rest of us drink water, really. But coffee has really a neutral effect on lipids, has a neutral effect on cardiovascular disease, a neutral effect on all-cause mortality. Only thing it affects really when you look at it genetically is that it reduces the risk of gallstone disease. So please drink coffee. It's good for you. Just keep going. I think tea the same. Maybe Prof. Ray has more comment about tea. That's a British thing, really. Yeah.
No, I mean, I basically, I've always been slightly confused about the dietary studies simply because of the fact that when you change one thing, you replace it for something else, and it's very difficult to, you know, we've got a lot of misleading answers from dietary epidemiology studies. So I think there are things you can measure. Essentially, you can do anything you want as long as your blood pressure and your LDL and your ApoB doesn't change.
Thank you. There's nothing better than
coffee.
A cup of tea.
Keep it, drink coffee and tea, that's just fine. But don't pour too much sugar in it or milk. I mean, just the pure thing.
Okay, and the last question from the chat is from Dr. Salim Bastaki, who, please can you put this to bed, is asking whether lowering cholesterol will affect the production of sex hormones, testosterone and estrogen.
No, I mean, Borg, you maybe want to take that, and I can give my view as well. Do you want to go first?
Yeah, sure. I mean, there's absolutely no evidence that should be the case. And the problem with human beings is that they have too much cholesterol, not that they have too little, because of the diet that we eat. From a normal physiological point of view, it's plenty of cholesterol having very, very low levels. You don't need very much to produce estrogen and testosterone. So no evidence at all.
And there are genetic variants, and the classic ones are those people that genetically have very low levels of ApoB or PCSK9, loss of function mutations, where they, from birth, really very low levels, and normal hormones, normal fertility, normal intellectual development, and so forth. So there's no real issue.
Having said there are no more questions, there are zillions of questions now, but I wonder if I can ask mine. What do you see as the role of common old garden omega-3 or combined N-3, N-6, EPA and DHA, now that we know about reduce it? Have you stopped completely using Omicol?
Personally, I never ever advised using over-the-counter fish oil, because there's no evidence that they are good for anything, except for the ones that sell them. They make a lot of money. I mean, that's the only thing. What the evidence is very good for is that population that eats a lot of fish, they do much better. They have less coronary heart disease. They live longer. So please eat fish, but not fish oil tablets. That's my point of view from the literature anyway. And
yeah, no, I completely agree with you. I mean, if you look at Vital, Marine, if you look at the Oxford trial as well with low doses, then basically they don't do anything. And, we've got Reduce It. It's a very high dose. I think if I'm I mean, I was involved with strength, so, there's a declaration there, but until we do almost you won't get a body count study, but maybe the answer is a 4-way imaging study with Epanova, with EPA, with mineral and corn oil, a bit like Evaporate was done, which was an MRI study that was done. That might give you a signal for where the truth lies. I'm still not 100%. I've never used the low doses.
Okay. Next question. You've both alluded to LPA. One of the issues I've found as a diabetologist is if you measure LPA in anyone whose diabetes is poorly controlled, it will invariably be high. So can we have some guidance on when to measure LPA?
Borg?
Well, measure LPA in everybody once in a lifetime, but you don't need to measure it very many times. There's this thing about that women, after roughly about age 50, levels tend to go up. And of course, at some stage when we have drugs that can lower LPA, then it makes sense to measure it repeatedly to see if you bring it down. But I'm not aware of what you say. Maybe you see it, but when you look at all the literature that diabetic people in particular have high LPA, it's actually, there's a very strange finding that if you have very low LPA, you have higher risk of diabetes. But still, I think it's very worthwhile measuring LPA in everybody at high risk to see if they have this additional high risk, and then you would focus more on reducing other cardiovascular risk factors, LDL, triglycerides, smoking, blood pressure, and so forth.
But Borg, and I don't know, I mean, from your lab, you could probably answer this, but normally, so for example, you don't see huge fluctuations, and what our wisdom is that diet and lifestyle traditionally don't affect LPA measurements because it's principally genetically determined. And the only treatment that we've got currently are the MABs, which, with on average 25, 28. So I'm intrigued. I mean, I think it will be, you'd have to do a trial of people with poorly controlled diabetes, a better glycemic control, and whether that I'm not aware of any studies that have shown better glycemic control in a randomized fashion will improve LPA.
No, not at all. I'm just saying that there's this very strange finding and we don't really understand it. And I'm not saying that if you lower Lp(a), you'll get more diabetes. I don't think so. But it's just there's a very peculiar observation in many observational studies, and even genetic studies. Some find it also. But I think that's different thing, a different story, really. Yeah, not to worry about high Lp(a), not worry about the low and diabetes connection.
It's not a lot individual patients, but in the people whom I've seen, repeating an Lp(a) when their HbA1c is 2 or 3% better tends to improve. And I'm not sure. Anyway,
how much improvement?
Significantly. So 40, 50% reduction.
Really?
Yeah.
Okay. Borg, there's a paper here.
Yeah.
Can I be a co-author?
I fully accept your personal clinical.
The idea came from Sarah.
Yeah.
Absolutely. And we've got 480 witnesses.
Yeah.
Okay. And then the next couple of questions for Professor Ray, really. In your case, you discussed repeating the calcium score at 5 years for someone with a low or intermediate risk. Realistically, how often can you do that? And can you give us some guidance on when to do a CAC score and when to repeat it?
I mean, so there are a lot of patients who are reluctant because they are invariably young, and they're not young, but they feel that they're too young to start medications. So the average rule of thumb that most people, so with some of the guidelines they talk about, is repeating somewhere between 5 and 7 years. And so what you're trying to look at are trajectories. The best way of thinking about this is if I'm already on a trajectory, think about babies in utero, and you look at growth curves, and some people may not have lived long enough to actually show up on that growth curve and trajectory. And you're trying to make an estimate of, is it a steep slope or is it a shallow slope? So if I appear after 5, 6 years, where I'm in the bottom 10, 15th percentile for risk, I might still accept that. If all of a sudden now, in that window, I've gone into the 60th, 70th percentile, I might now take intervention quite seriously. So normally we talk about 5 to 7 years as a rule of thumb. And the dose of radiation is really low.
Yeah, I think we're an insurance-based system here. It might not go down very well, but your point's well made.
It's getting cheaper, actually. It's getting much, much cheaper. And interestingly, it's one of the things, here insurance companies I can't get even for cascade testing. Most of them have to self-pay for FH. But I can get a CAC scan. They'll all, pretty much, which is bizarre.
Very good. We might need to speak about that. And my final question is, as far as I know, all the Orions were actually inclisiran on top of statin therapy, but you alluded to the poor compliance, and it's a huge issue in the UAE. Do you know of any evidence of inclisiran actually?
There's a small group of people who were not on statins. I mean, so when you do a trial like that, it's for regulatory purposes, because the FDA said, hey, show us it works in that group. So we weren't trying to study statin intolerant patients, but there were a few. And out of 3,600 patients, we've probably got 300 or so not on statins, and you've got a similar percentage reduction. These people who are statin intolerant, their baseline LDL is much higher. So that same percentage reduction is giving a bigger absolute lowering.
That's really helpful. Thank you. We've still got a little bit of time, so I wonder if I can go back to the questions. In someone with end-stage kidney disease on hemodialysis who does have an MI, do we need to give high-intensity statin plus or minus ezetimibe? And if yes, what is the target LDL? From anonymous attendee.
Yeah, I mean, my thought is that if you look at the SHARP trial and then you look at meta-analysis, so if you basically look at Aurora, if you look at also the atorvastatin trial that was done years ago, basically end-stage renal disease, you've got dialysis. I wouldn't discontinue somebody necessarily on a statin, but I wouldn't necessarily start a statin with ezetimibe. The reason is they've got high risk of cardiovascular disease, but the events that are occurring are heart failure hemorrhagic strokes, and arrhythmias, which are not modifiable with typically lipid-lowering treatments. So there is no goal, and I wouldn't initiate treatment myself.
The next question is from Dr. Afra Ogaili, who asks whether statins are associated with hypoglycemia, so impaired fasting glucose or IGT, in a non-obese and active person.
No.
Okay, thanks. Short and sweet. Next one. Can you give dual statin therapy?
Well, it's definitely not recommended, and there's no need to it. And of course, there's this chance of you could have more side effects with the myositis. But my old boss, the professor before me, he used to he really believed in that, so he took dual therapy. But I think this is on a case basis only. It's I would just use 40 milligram atorvastatin, 80 milligram atorvastatin, or 40 milligram rosuvastatin, and then combine with something else.
Yeah.
Next, I'm going to speed up a bit because we haven't got very much time and quite a few questions. Any questions that are not answered, if you put them on the website, hopefully you'll get an answer to. So another end-stage renal disease, which statin, and they're statin naive, which one would you prefer? And the maximum dose you would use?
So, I mean, end-stage renal disease, we wouldn't, think about CKD5 or dialysis. If you were using a statin, let's say in CKD3, in particular, there is some evidence that atorvastatin is slightly better than rosuvastatin. And this was basically, there were a couple of head-to-head trials that were done looking at things like proteinuria. Now, whether that's a chance finding based on small numbers or so forth, but it was repeated in both people with and without diabetes. So probably a low dose of statin. The only thing you've got to be careful about is in some of those people going up to 80 milligrams of atorvastatin, particularly with drug-drug interactions, you might get more CK abnormalities. So probably in that group, I would think certainly not 80 or 40 of the top doses of statins, a slightly lower dose in combining with non-statins to achieve the desired level of LDL lowering.
Yeah, I fully agree. There's a lot of early evidence for more muscle symptoms and CK elevation. So be careful, start with a low dose. And I mean, there was some discussion, one was better than the other in the beginning, but I would just start with low dose, maybe, 5 milligram atorvastatin or something, real low, yeah. And then take it from there, yeah.
Thank you, that's really helpful. Someone with a high risk of cardiovascular disease and dyslipidemia on, doesn't say which statin, 40 milligrams and ezetimibe, LDL at target, but triglycerides still high. I think you've answered that already. I'm going to change, they've said omega-3 or fenofibrate, but icosapent or fenofibrate.
What's your favorite, Borg, now of the two? If you had a patient,
I don't know. I always think that the evidence for using fibrates, fenofibrates, is very good if you look at the ones that have high triglycerides.
Yeah.
I know this has been, so many people have argued against the fibrate trials, but that's because the fibrate trials were not designed to show what is the effect of triglyceride reduction. They actually all recruited people with high LDL. So these were LDL trials. But if you look at the sub-analysis, all the ones with high triglycerides that get any sort of fibrate, they have clinical benefit. So I think that's pretty safe. Icosapent ethyl, sure. I mean, as Cosray said, I think there'll be more discussion about that. How much is the true effect, and is there some of the effect that is due to a harmful effect of the mineral oil being the control or comparator oil, you could say. So, but of course, it looks like the effect of icosapent ethyl is very favorable. So, of course, there's also a question about money. So it's if you have a lot of money and you can afford icosapent ethyl, this is very good. But if you have less, then I would use a fenofibrate.
So I guess for both of you, better the devil you know than the devil that's just come around the corner.
Yeah, and I'll throw another one in, Borg. I mean, the other option also is the use of a MAB. I mean, because if you take people with a high triglyceride, their ApoB and non-HDL is so high, you can actually improve the clearance. LDL particle number goes down, ApoB goes down even more than with the fibrate. in that group. And so, you know, as you say, cost may be a limitation, but we've got pretty good evidence for the ApoB. Now, it doesn't matter how you lower it. If you get a big reduction with your fibrate, fantastic, you're happy. And that's the way I would think. I can understand most things in relation to ApoB or other atherogenic lipoproteins. And that's the bit we don't know, right? Nobody's going to do that head-to-head study. We've done a few, but they've been lipid studies, not body count studies.
So of course, I mean, the first thing I would advise with this particular patient is to make sure that the statin that is actually given is the dose that will reduce triglyceride lipoproteins the most, and that is atorvastatin 80 milligram or rosuvastatin 40 milligram. So make sure those, and after that you can consider either icosapent ethyl, fenofibrate, or as Cosway says.
And I think the other things are weight loss, looking at if they're diabetic, improvement of glycemic control as well. You know, don't chase downstream, look at what you can chase upstream. And it's not really an issue in, you know, in your part of the world, but here, alcohol intake.
No doubt.
Yeah.
Okay, next question.
No doubt the best is weight loss, but I try to tell myself that many times that it doesn't work. I don't lose weight, so I think they'll be the same with many patients, really. Not you, Cosway, you lost weight, actually. You're a handsome guy.
I've lost a lot.
Well done. Okay, next question. If someone has rhabdomyolysis, one assumes following statin therapy, what would be your next choice?
Yeah, so I mean, you look at what was a triggering factor or if anything else. I mean, I think rhabdomyolysis is one of those things that you would never go back to another statin. So now, depending upon the level of risk, you'd start off with ezetimibe and probably think about a monoclonal.
Yeah, I agree.
Brilliant. Next question. Starting statins early is key in patients, but why do risk calculators start from the age of 40?
Because that's the population studied, right, Borg?
Yeah, I think so, yeah. And so, like, we did that in the Copenhagen young population study. I showed you that paper from the Lancet because we recruited people from age 20 to age 100 years. So we can calculate the risk is high already at age 20 to 40. I think the main reason also is that the absolute risk in age 20 to 40 is quite low unless you have familial hypochondria. Of course, if you have type 2 diabetes already at that stage will also be high, but that's the main reason. Yeah. So if you don't have FH, if you don't have type 2 diabetes, then the risk from age 20 to 40 is quite low.
Okay. Thanks for an excellent lecture. In someone who's 45 years old with a ASCVD calculated risk of 3.5% and a long-term LDL of 4, shall we start a statin?
Yeah, it's a difficult one. So with that, essentially the gain long-term cumulative exposure will be quite good. So you try diet and lifestyle, you might want to think about further risk stratifying with imaging. My rule of thumb is I'll have conversations about short-term versus long-term, and the guidelines allow you to do that. You know, and if somebody, you could say, look, your short-term goal is going to be really small. However, we're not interested now. It's like putting money into the bank. You put a little bit away now, in 40 years' time, you will have a lot more benefit. If you make that decision 30 years later, you've got more advanced atherosclerosis. So I'm not going to have to use a bigger treatment effect. So there is no right or wrong answer. I would just say, present the benefits, present any potential downsides, how you would manage that, and let the patient choose. It's not absolute.
Yeah, I have the same. If the patient is interested, I would definitely offer a statin. I wouldn't go to the top dose, but I would go to some medium low dose. Be perfectly fine. Just a good example is just myself. I mean, I'm not really sick or anything. When I was turned 50, I just gave a statin prescription for myself as my birthday present, really. So it's depends on the patient, really. Yeah.
Okay. The next one's a really exciting one. So how does do long-term ketogenic diets create an adverse cardiac risk?
Once again?
Ketogenic diets and lipid profile.
A lipid profile, long-term ketogenic diet.
Of course, Ray, you're the smart one. You can answer this one.
So I can tell you about one of my couple of my patients that, so that where we do see a lot of people wanting to do ketogenic diets to lose weight, and the lipid profile can change by as much as about 2 millimoles. So one particular person, his GP referred to me as, was this FH, and you take a history of them, and he's doing this ketogenic diet, and his lipid profile is bizarre. And then as soon as he actually just modifies that a little bit and does something a bit more balanced and sensible, his LDL's down by about 2 units. So if he maintains that, yeah, he's got the weight loss, but an LDL 2 millimoles higher for the next 50 years.
Not keen.
Yeah, I'm not advising it either. No.
Okay. Okay. What about GLP-1 agonists and lipids?
Indirect
weight
effects.
loss. Yeah.
So you get indirect effects on weight loss, and if you get weight loss, you'll improve trigs and HDL. Direct effects on lipids are much more modest in comparison to what you get through weight loss, mediated through weight loss. Borg, I mean, this is your kind of laboratory work, and any additional bits that you've seen? I mean, I think it's all weight loss.
Oh, sure. Oh, yeah. I mean, the weight loss part. I mean, I think some of the companies like Novo Nordisk, they are running trials particularly for weight loss using drugs like that. Yeah. So, and weight loss is probably good. I mean, it's but yeah.
Okay. I think we've done most of the questions. Oh, one more question. So fatty liver, is there a recommended statin that you would prefer? And if the ALT does rise above 3 times, what would you do?
Well, yeah, I mean, I don't know. I basically, I mean, we use rosuvastatin, atorvastatin, usually start with slightly lower doses, and you would just monitor a bit more carefully. The rule of thumb is if you get more than the 3 times your starting level, your baseline levels, then you would discontinue. And you might basically look at weight loss. And so the main way you're going to improve the fatty liver is weight loss. So you might look at introducing, you might actually have a statin re-challenge, but later at a low dose. If there was an absolute reason you couldn't use a statin, you'd go down the ezetimibe, potentially MAB route again.
But of course, we don't have any evidence that some of the statins are particularly dangerous when you have fatty liver disease.
No,
right?
no, we don't. And I think it's just, you're absolutely right. And in fact, remember the Greece trial, the main paper was in a lesser journal, and the one on people with fatty liver was in the Lancet. It was really interesting because they showed not only 10 milligrams atorvastatin being safe in the people with the higher baseline, but getting absolute benefits because they had more risk. But I mean, Borg's absolutely right. We don't have any evidence. But the only thing I would say is there's a big difference between somebody who continues to get elevations through exposure to the drug versus a small bump up in LFTs, and it stays there. So if you get a small bump up, but it's not continuing to go up, I think the benefit is to continue with those treatments. But if it's continuing to climb, then I think, either discontinuing and doing other things might be sensible clinically.
Brilliant. Thank you both very much for amazing talks and a fantastic discussion. We really enjoyed it. We're going to move on to the third speaker. So our third speaker tonight is Professor Alberto Gambon, who's an associate professor of medicine at the University of Padua in Italy. He's an assistant professor of medicine in the Division of Endocrinology, Metabolism and Nutrition at the University of, sorry, I can't see that. School of Medicine, University of Washington, Seattle. His main clinical interests are in the care of patients with premature atherosclerosis and patients with lipid disorders. And tonight he'd like to speak to us on PCSK9 inhibitors in hypercholesterolemia, new hope for patients with diabetes. Thank you, Professor Gambon.
Thank you, Sarah, for a very, very kind introduction. And thanks also for colleagues actually that are still with us so late. I hope I'll be able to give you some practical information about the challenges that are related to treating people with dyslipidemia. Of course, my life has been made much easier by Professor Koch-Ray and Professor Borg and Nordahl and their talks. This is my faculty disclosures. And as you've heard from Professor Ray, patients with diabetes are at very high risk, even if they do not have cardiovascular disease, but they have a target organ damage, for example, or more than 3 risk factors for cardiovascular disease, or even high risk if they have a shorter duration of disease or without any target organ damage. But they fall into the category of very high and high risk, particularly very high risk, even without cardiovascular disease, which means they have a very challenging goals for LDL cholesterol, which remains the target number 1, as we've heard from Professor Ray and Professor Borg and Nordahl. Less than 55 milligrams or 1.4 millimole is the challenging goal for these patients. If they are at high risk, is 1.8 millimole or less than 70. And the stepwise approach that we've heard suggested by the most recent European Society of Cardiology and atherosclerosis guidelines includes 3 steps. Starts with the high-intensity statin therapy. If the goal is not achieved, combine ezetimibe, and at the end, if the goal is not achieved, the combination statin and ezetimibe, use a PCSK9 inhibitor. We've heard, and I'm going to develop a little bit that concept that this is probably not up to date completely, given the very low levels of LDL goals. Probably we should think about starting with the combination of high-intensity statin therapy and ezetimibe. I'm very in favor of that approach. And of course, in certain situations, the use of PCSK9 inhibitors changed the level of LDL cholesterol we can reach to our patients. Professor Koch-Ray suggested that statins are very effective in decreasing cardiovascular events in patients with diabetes. And here we have 6 statin trials where, as you can see, in patients with diabetes, the treatment with statin decreased as compared to the placebo group, the events observed in 5 years. Now, so no question, statins are effective in decreasing cardiovascular events in patients with diabetes. Let me show you in the very same trials those that did not have diabetes, without diabetes, treated with statins and non-placebo. And as you can see here, in most of these trials, the levels of events observed in those on statin therapy with diabetes was higher than those that had no diabetes but received no active treatment, which of course raises a lot of questions in terms of clinical events being relatively high. Now, let me point out that in TNT, the placebo was 10 milligram of atorvastatin, the statin therapy was 80 milligram of atorvastatin. So the message from TNT is that those with diabetes on 80 milligram of atorvastatin had 14% events in 5 years. Those without diabetes on 10 milligram of atorvastatin had a lower event rate, once again suggesting that there is a road ahead that we should explore to further decrease the events. One in the IMPROVE-IT trial, once again mentioned by Professor Koch-Ray, suggested that the addition of ezetimibe was associated with the further decrease in cardiovascular events, suggesting that no matter how you decrease LDL cholesterol, by decreasing LDL cholesterol in terms of absolute decrease, milligram per deciliter or millimole per liter, you decrease cardiovascular events. But let me show you the population with and without diabetes. The black solid and dotted and dashed line describe the event rate during the follow-up time in those without diabetes. And as you can see here, there is not much of a benefit by adding ezetimibe to simvastatin. These are the curves, the red ones, that refers to patients with diabetes in IMPROVE-IT. So these are very high risk post-acute coronary syndrome patients treated with simvastatin or simvastatin and ezetimibe. I like to point out that the group of simvastatin and ezetimibe had a 1.4 millimole per liter of LDL cholesterol, which is exactly what is suggested by the current guidelines. Now, the number one observation is that the 2 red curves are much higher. And again, no surprise, those with cardiovascular disease and diabetes, particularly diabetes, have a particularly high risk of cardiovascular event as compared with those that do not have diabetes, even after an acute cardiovascular syndrome. But the other point is that there was a much greater benefit, minus 14% relative risk reduction, 5% absolute risk reduction in those with diabetes treated with simvastatin and ezetimibe as compared to ezetimibe. 70 milligrams or 1.8 in those with simvastatin, 1.4 the goal for very high risk people in the IMPROVE-IT trial for the simvastatin and ezetimibe. Once again, much greater reduction as compared to those without diabetes, but the 5-year risk, once again, around 30%. So still a road ahead. So we need a more aggressive reduction, as Professor Koch-Ray mentioned, and Professor Borg and Nordahl also confirmed. We need to lower the burden of ApoB containing lipoprotein. So again, very good results from the IMPROVE-IT, particularly in patients with diabetes, but probably more to do in terms of clinical events. Now, as Professor Koch-Ray mentioned, when we moved from the 2016 guidelines, LDL cholesterol goals for those at very high risk, 1.8 millimoles, to the 2019 guidelines, a more aggressive and lower LDL goal for the very same population, 1.4 or less, the number of patients in real life, particularly very high risk, as you can see, 4 categories here, all at very high risk, that achieved these goals halved. We had about 40% on 2016. We dropped down to 18% to when we look in the Da Vinci trial at those achieving LDL goals in the very high risk group by the goals suggested in 2019 guidance. So 1 in 5, suggesting that there is actually an issue, a clinical challenge in achieving these goals. The explanation comes, as Professor Ray mentioned, to the fact that we cannot achieve such a low goal. It's a mathematical issue. We're not able to reduce the LDL cholesterol above a certain or beyond a certain point by using statin monotherapy. And I think this meta-analysis of 8 statin trials where intensive versus a more actually conventional statin approach was used shows. So remember, these are intensive versus a more moderate statin approach. An intensive approach means 80 milligram of atorvastatin or 40 usually. Let's focus our attention on the red bars. It's LDL going down progressively from the right to left, 1.75 down to 0.50, which is 1.4 millimoles. The height of the red column decreases progressively, confirming that the lower the LDL cholesterol achieved on trial, the lower the hazard ratio for major cardiovascular events. So there is a group of patients who achieved an LDL cholesterol below 1.4. So why are we talking about the fact that we are not able to achieve such a low goal? And this is the target LDL goal for the very high risk. Because when we look at the percentage, and these are trials, randomized trial, very good adherence. So it's an optimistic view of what we really see in the real life. Only 5% of patients were able to achieve an LDL less than 1.4 in this randomized controlled trial on high-intensity statin therapy. Once again, suggesting that monotherapy is not enough. And I'd like to point out the slide that Professor Ray already showed. The high-intensity statin is used in about less than 30% of the patients. Very few statin ezetimibe. Mostly is used the moderate intensity statin as a monotherapy. So we are way far away actually from implementing actually or using in real life a lipid lowering approach that would be able to achieve or get our patients close to the goal of 1.4 or less. So again, very few people achieving high intensity or receiving high intensity statin therapy, and even fewer people combining the statin therapy with ezetimibe. This is an update that I'd like to show you that was published last month from an expert group of the European Atherosclerosis Society, moving towards a more aggressive, approach for LDL lowering in patients with very high cardiovascular risk. Let's focus on step 1. Basically, the guidelines, practical algorithm for managing very high cardiovascular risk people suggest that if a patient is on a statin, but the LDL remains above 1.8 millimole, you shouldn't move straight away to high-intensity statin and ezetimibe. No matter what statin is using, no matter what dosage is using, if the LDL remains above 1.8, you should move to a high-intensity statin therapy and ezetimibe. The other interesting point is that if the patient at the very high risk has no statin on board, so it does not receive any statin therapy, and the LDL is above 2.6, you should not waste time, go straight to high-intensity statin therapy and ezetimibe. So basically, the combination of high-intensity statin therapy and ezetimibe, this treatment is the first choice suggested for managing high LDL cholesterol and should be given upfront in very high cardiovascular risk patients. Of course, if you look at the bottom of the slide, the PCSK9 should be added, of course, if the level of LDL cholesterol in the patients remains high, as a step 2, not as a step 3. The step 1 is a combination of high-intensity statin and ezetimibe, and if that is not enough, then the PCSK9 inhibitor comes in. I'm going to run very quickly. This is the Fourier trial suggesting how much we can improve our LDL cholesterol by using evolocumab. In this case, very large number of people, follow up on average 26 months, the median, very good background therapy, all on statin therapy, about 70% on high-intensity statin therapy. This is the background therapy, so keep in mind the placebo group in this study was high-intensity statin therapy for 70% of the patients. Very good other background therapy, double anti-aggregant, beta blockers, ACE inhibitors, ARB, or both, actually, monotherapy or both. So very good background therapy. You know that the baseline LDL cholesterol was 92, and that was observed throughout the study in the placebo/high-intensity statin group. And those who had evolocumab on board lowered the cholesterol down to 0.8 millimoles or 30 milligrams per deciliter. And this is the median, which means half of the population had an LDL cholesterol below 0.8 millimoles, so very, very low. Now, as compared to the high-intensity statin background therapy, the addition of evolocumab and the achievement of such low levels of LDL cholesterol in a median time of 26 months was able to further decrease the cardiovascular events by 15%, and that was, the events are listed here, and that was significant. Of course, you've seen the Odyssey outcome data with alirocumab, similar results. One can be actually worried about having such a large number of people achieving such low levels. And if you look at the numbers here, the green and the red columns, those who achieved an LDL cholesterol less than half millimole or between half millimole and 1.3 are about 10,000 people, so a large number of people. And as you can see, serious adverse events that led to discontinuation of therapy, new onset diabetes, any type of cancer, cataract, neurocognitive disorder, significant increase in transaminases, CK, non-cardiovascular risk of death, and hemorrhagic stroke were not increased in any of these LDL groups, including those with a very low level of LDL cholesterol, which seems to be safe. And of course, the real-life data that are collected after the introduction in our armamentarium of the mAb monoclonal antibodies confirms the lack of serious side effects, even for those at very low levels of LDL cholesterol. But the good point is that, on the other hand, the linear correlation or relationship between progressively lower LDL cholesterol and progressively lower event rate was confirmed even for low levels, very low levels of 0.5 or less. If we have if we look at the event rate in those with 70 to 79 milligram per deciliter, we can see that the event rate is decreased by 10% as compared to the reference group with an LDL cholesterol above 2.6. But if we look at those with less than 0.5 millimole per deciliter, the event rate is further decreased by 31%, suggesting that the linear relationship holds true even at the very, very low levels of LDL cholesterol. Now, we're talking about patients with diabetes. The Fourier trial had specific publication, a group of patients with diabetes. And as you can expect, those with diabetes had a higher event rate. I'm focusing the attention on the left-hand side panel. The right-hand side are those in Fourier without diabetes. Fourier studied people at a very high risk with the cardiovascular events of peripheral artery disease. And as you can see here, this is the placebo group, high-intensity statin, 17% event, very high event rates in 36 months, a significant reduction of 2.7 absolute risk reduction, 17% relative risk reduction, number of patients needed to be treated, 37 in those on evolocumab that reached an LDL cholesterol of 0.5 millimoles or 0.8, millimoles or 30 milligram per deciliter or less. So a significant decrease, greater absolute risk reduction due to the very high initial baseline cardiovascular risk of these patients as compared to the non-diabetic population, where the absolute risk reduction was 1.6, and the number of patients needed to be treated was a much higher, 62 versus 37. So a further, more aggressive approach, even in patients with diabetes, reducing ApoB-containing lipoprotein and particularly LDL cholesterol, further reduces in Fourier the risk of cardiovascular events, cardiovascular death, non-fatal MI, non-fatal stroke, hospitalization for unstable angina, and coronary vascularization. The good and interesting news is that unlike the statins, it does not seem that the PCSK9 inhibitors, the therapy is associated with any increase of new onset diabetes, and those both in patients with previous diabetes, without diabetes, and worsening of the glycemic control in those with diabetes. As you can see, at the end of the year, at the end of the first, second, and third year, there is no trend showing an increased risk of new onset diabetes in those on evolocumab as compared to those with placebo. Now, HbA1c, as you can see here, those with diabetes at baseline, the bottom is those without diabetes at baseline, no changes in the HbA1c or no differences between the two groups throughout the study. Fasting plasma glucose, once again, no significant changes, suggesting that the use of, in this case, of course, evolocumab was neutral in terms of glucose control, in terms of new onset diabetes, and particularly quite safe. So it was effective in terms of decreasing cardiovascular disease and not associated with any worsening of the metabolic control of glucose or new onset diabetes. So quite interesting. The real impact on the real life of the use of PCSK9 inhibitors comes from the preliminary results from the Heyman study. These includes patients with adults greater than 18 receive evolocumab as part of the routine clinical management, not as part of randomized clinical trial. You see the countries in Europe involved, and the patients enrolled, of course, receive the PCSK9 according to the guidelines of a specific country, allowing them for the use of PCSK9 on top of the available background therapy. About 2,000 patients, once again, 11 countries. The follow-up was until 2019, October. These are the starting point, so about 4 millimoles or 154 milligrams, very rapid and quick, effective reduction in LDL cholesterol that basically is maintained throughout the observation, the 18 months of observation, and the reduction is on the range of 56-59%, confirming what has been seen in the Fourier trial. So an effective reduction on top of the available therapy maintained across an interesting period of time. So maintained across time. Interestingly enough, looking at patients who achieved an LDL cholesterol less than 1.4 or 55 milligram per deciliter, overall 58%, so more than half. But let's focus our attention on those who have a background therapy of statin and ezetimibe, which is suggested, highly suggested before using PCSK9 inhibitor. Well, those who achieved an LDL cholesterol, very high risk people, less than 1.4 were 67, almost 70% of the people. So a very interesting, remarkable results by using a PCSK9 inhibitor, evolocumab, in real life in Europe, 11 countries. If we look at the distribution of a calculated 10-year risk in three ways, the Rich equation, the Fourier trial, and Fourier-like observation, the red curve is the distribution of the estimated cardiovascular risk, 10-year cardiovascular risk before the evolocumab, and with the evolocumab, there is a shift, and that's the green area. There is a shift, no matter what calculator we are using, towards the left, towards lower cardiovascular risk once you use evolocumab, again, as compared to the pre-treatment cardiovascular risk. 10-year cardiovascular risk improved no matter what calculator we are using by the use of evolocumab. Let me finish the last two slides to remain within the time limits, looking again at the ESC most recent guidelines that suggest in patients post-acute coronary syndrome to use the highest dose of high-intensity statin therapy that is tolerated by the patients regardless of the initial LDL cholesterol. But once you use also ezetimibe, please consider PCSK9 inhibitors if you have a patient already admitted with an acute coronary syndrome who has a statin therapy, or maybe a statin and ezetimibe. Consider the addition of a PCSK9 inhibitor early after the events, possibly during hospitalization, so before discharge, for two reasons. Of course, one is that this recent analysis of the Fourier suggests that adding the PCSK9 in patients with recent MI, an MI that happened before or less than 12 months before the addition of evolocumab, as compared to the placebo therapy, identify patients who have a greater benefit in terms of greater reduction, once again 3.7 absolute risk reduction as compared to those who had a remote event, The 1.1 is the absolute risk reduction. 3 years NNT is only 27. But the other point is that the number of patients who had discharged already achieved the LDL goal is amazingly high. This is the EVAC study. Is basically an analysis of patients that were admitted for an acute coronary syndrome, and they were either treated with top dose of high-intensity statin therapy, the blue columns, or the same background high-intensity statin therapy and one shot of evolocumab within 24 hours from the admission. Now they look at the LDL cholesterol level at hospital discharge on average 4 days after the acute coronary event, and 65% already had an LDL cholesterol less than 1.4. They looked again at the lipid profile a month later after the discharge. 85% of those with evolocumab and the background therapy of high-intensity statin plus or minus ezetimibe had an LDL cholesterol 1.4. So an amazing number treated appropriately already at discharge, and even more so after 1 month. So this is my last slide. This is the flow chart that you've seen time again and again, published in 2019. I think there is plenty now of practical evidence that to achieve the goals of less than 1.4 millimole per deciliter in our very high risk patients with diabetes, even without coronary artery disease, but target organ damage, or at least 3 risk factors, we should really focus on using high potency, high intensity statin therapy and ezetimibe right away up front as a step 1 approach. In those with diabetes that do not achieve the LDL goals, of course, according to the national guidelines and eligibility criteria, we should consider as a step 2 approach with the class 1A level of evidence, the use of a PCSK9 inhibitors. I stop here, and again, I'm available for Q&A. Thank you very much for your attention.
Thank you very much for a lovely talk. We've got time for a few questions. I think initially we thought 2 or 3, but we've probably got a little bit more time than that. If I may start off with a couple of questions. Firstly, do you think there is any difference between MABs, between PCSK9 inhibitors, or is it a class effect?
Actually, we've been using since 3 years almost and extensively in Europe and throughout the world. And I would say they're quite effective. They're very effective, in fact, and safe. I do not consider any significant difference. I think the 2 studies approach the problem in a different way. The Fourier, the lower the better, no matter how, and they reach very low levels. The Odyssey outcomes that Professor Ray and Professor Borg and Nordahl mentioned was a kind of treat-to-target approach, modulating the dose of the PCSK9 alirocumab according to the levels of LDL cholesterol. I'm very confident that the lowest the better is true, it's safe. Again, they're both effective. There is only, the choice of 2 doses on alirocumab, a single dose on evolocumab. The effectiveness is similar, and again, plenty of experience with both. Safety is great, effectiveness is great. 140 evolocumab works extremely fine. In certain situations, you can use 420, a single shot, that particularly patients with FH. But effectiveness and safety, they're great. They're both great.
Thank you. That's really helpful. Next question. Your evidence for diabetes is very well taken, and it's been there for a long time. I don't know if you could share with us your expertise on whether control of diabetes, i.e. poorly controlled versus well-controlled diabetics, if there is a difference in these groups.
There is not much of a difference, in fact. I think, it's good that they do not impact, although as Professor Koch-Ray mentioned, we should not be worried about using statins in terms of worsening diabetes. That's not a worry. But it's very nice to see that the PCSK9 inhibitor is completely neutral in terms of glucose effect. And I would add ezetimibe as well. Ezetimibe as well is completely neutral. So the further step you can use once you're not happy with the statin, both ezetimibe and PCSK9 inhibitors are completely neutral in terms of diabetes. If I may add, there are recent meta-analyses too, actually, in fact, suggesting that particularly ezetimibe might be particularly effective in patients with diabetes. Keep in mind the mechanism of action. It decreases absorption of lipids at the intestinal levels. Postprandial lipemia is one problem in patients with diabetes, so ezetimibe has the chances to impact not only on LDL cholesterol levels, but on postprandial lipemia, much more than a statin, for example. So that's why, to me, I think starting ezetimibe and PCSK9 inhibitor, but ezetimibe on board is really key for cardiovascular disease prevention in patients with diabetes.
Okay. One of the issues we have in this region is that it's an insurance-based system. Yeah. So we do need to select very carefully who we're going to treat.
Absolutely. The same thing in Italy, although it's not insurance, it's public, but because of the cost, we need to select the patients as well, yes.
Yeah, so obviously secondary prevention, it's a no-brainer. But in primary prevention, how long would you give high-dose statin and ezetimibe before you decide to move on to the PCSK9? And are there any groups that you would maybe auto-select earlier?
I think the very high risk suggested is a target organ damage, diabetic retinopathy, nephropathy, neuropathy, or patients with a complex set of risk factors and diabetes are definitely my first choice. I would not wait longer than 3 months. Actually, if you look at the time lapse that is suggested by the guidelines between steps of lipid lowering approach is 8 weeks, 8 plus minus 4 weeks. In those post-acute coronary syndrome, it's only 4 to 6 weeks. So I think the time has squeezed a little bit between changes in therapy and checking out the lipid profile before moving on. Again, if you want to be sure, I think 3 months at the most, you check again your lipid profile, and if the goals are not reached, of course, you move on. The insurance is an issue, even in Italy, for example. And I think, considering the investigation of peripheral artery disease or carotid ultrasound is something that in patients with diabetes who did not have cardiovascular events, cardiac events, might help in identifying those who have a greater, even a far greater benefit by using PCSK9 inhibitors. So you can use non-invasive measurements of peripheral atherosclerosis to get one step higher in terms of benefits as compared to costs.
Thank you, that's really helpful. There are a few questions on the chat. Some not directly relevant to your talk, but one of them is, what's the mechanism by which statins induce diabetes?
Well, it's complex, it's studies. I think one of the best available evidence is that they work on glucose transporter, and actually particularly at the pancreatic level. Overall, I would say, let me forgive the oversimplification, they basically decrease the insulin sensitivity within the islet cells, actually, the beta cells. Glucose transporter is one of the main mechanisms that has been studied, particularly GLUT4. Again, that seems not to be or to be impacted on PCSK9 by PCSK9 nor by ezetimibe. Again, let's keep in mind that this is not a problem for patients who already have diabetes, because the worst that can happen is a slight, of course, worsening in the glucose control. It's crucial for patients who have glucose intolerance, because you may basically move them up to patients with overdiabetes. So again, no worries, because the benefits far outweigh the risk. There is no question. But it's good to keep in mind that step 2 and 3, ezetimibe and PCSK9 inhibitor, are completely neutral to that respect.
Thank you very much for a lovely talk and for taking all these questions. We'd also like to thank all the attendees for staying online until now. The CME will be available in 10 days. Just to remind you that this is the first of a series of 3, and we'll give the details in a minute. You'll be sent an email for the evaluation, and when you return that, you'll be able to obtain your CME credits. The webinar will be available on demand on the Emirates Diabetes and Endocrinology Society's website and on the YouTube channel. Can we go on to the next slide, please, Cheryl? So the next couple of webinars are going to be on the management of dyslipidemia in special populations and the management of diabetic dyslipidemia on the 4th and the 25th of June. They're starting a little bit later at 7:30. There are also other events which are hosted by the Emirates Diabetes and Endocrinology Society, including the cardiometabolic series with the following dates. There's the Young Leaders Forum, which is absolutely excellent. I'd highly recommend it. And the Emirates Diabetes and Endocrinology Society Connect. Please do visit the website for more information. Thank you all very much for patiently staying on until 9:30, and we wish you a lovely end of the night. Once again, we'd like to thank our sponsors for an unrestricted educational grant from Amgen. Thank you.